I hope we all benefited from this very nice lecture. Guidelines are very important, especially in these emerging problems, which actually nobody has experience in. Please, if I have something to say, any one of us who have managed some COVID patients and may have an opinion in the management, please go with the recommendations and guidelines, because they covered much lot of cases, and they have seen so many standards in the management. So it's always better to go by these recommendations until every center can have its own or can ameliorate or change these decisions. It's always safer to go with this. Now, it's my honor and pleasure to introduce our next lecturer, Professor Gerrard Visser, Vaccination of Pregnant Women to Prevent COVID-19. Professor Gerrard is an emeritus professor of obstetrics in University Medical Center, Utrecht, from the Netherlands, executive board member of the European Association of Perinatal Medicine, member, executive board of European Board and College of Obstetrics and Gynecology. I welcome him very much, and welcome to Egypt, and thank you for being able to come to deliver this message by yourself. Thank you.
First slide.
Yes, sir.
Maybe you have the first slide, please. Ah, there it is. And there it is. Thank you very much, Mr. Chairman, and thank you very much for the invitation to come to Cairo. My first international meeting in 1 year and 9 months. Recently, I spoke to an English colleague who told me I became an academic because of the research and because of the traveling. And now that there is no traveling anymore, what am I doing here? I'm glad normal life seems to restart again. Vaccination of pregnant women, is it wise? Well, it's still decision-making in an era of uncertainty and with insufficient knowledge, and it's still like driving in the fog, although gradually more and more becomes a little bit more clear. If you look at the first wave of COVID, the initial reports indicated that pregnant women were not at increased risk. But that was unlikely, since we also know that of other viral infections, like influenza and pregnancy, they definitely do affect outcome and have an effect on maternal morbidity, mortality, and also more preterm births. Same holds for other coronavirus infections. There are not that many that have been published, but if you look at SARS and MERS, which you had in this area of the world, there is an increase in maternal ventilation and maternal mortality, definitely. And indeed, the data that we now know and heard, and also in the previous presentation, show the same. So, and pregnant women are likely to be at increased risk for severe respiratory disease, given the fact that oxygen consumption is increased and also lung volume is increased, and because of the fact that the immune system is somewhat repressed. If you look at the data from the Netherlands until May this year, nationwide database, 7,000 pregnant women with COVID, 400 hospitalized, and 36 ended in intensive care, and which is 2 to 3 times higher as compared to non-pregnant women of the same age. And this is consistent in the literature. Yes, they're likely to be affected by severe disease to end up at the intensive care. We didn't have maternal deaths among these 7,000, but I think that is very exceptional. If you look at most countries, you will find mothers dying because of COVID. Most of these women admitted to the intensive care had risk factors, and that's essential to know. their pulmonary problems, obesity, maternal age over 35. So those are the women, particularly at increased risk. If you go to the data of the CDC from the United States, publication from November a year ago, also they found exactly the same, a threefold increase in intensive care admission, need for oxygen and ECMO, especially again women with a risk factor. Risk factors is essential, high BMI, diabetes, hypertension. No obvious increase in fetal growth restriction. There was an increase in preterm births in the United States, but that was mainly due to induced preterm births, induced early cesarean section, and there was an increase in maternal mortality and the perinatal mortality, but the latter was only due to the increase in preterm births. So specifically for the fetus, they do not seem to be serious risk of COVID infection. And if you look at data on maternal mortality of low middle income countries, data from India, and especially a large series from Mexico show that COVID pandemic was associated with a 30 to 40% higher maternal mortality as compared to the year before. This is not only women dying because of COVID, but also maybe of indirect factors at the same time. So that's quite high. And nowadays in Mexico, COVID is the leading cause of maternal deaths. Similarly in Brazil and in other countries, even in high-income countries with adequate intensive care units, maternal deaths has been shown to be not infrequent. Your neighbors in Israel, small country, recently in 2 months, 7 maternal deaths, 6 of them were non-vaccinated. And we know that almost everyone in Israel is vaccinated. Indirect effects of corona are, of course, a reduction in the number of antenatal care visits, reduction in post-care, post-delivery care for women. So there are also indirect factors. And here in the Lancet, they calculated that may account up to 10 to 40% increase indeed in maternal deaths. And most low middle income countries, and there is special data from South America, who had a decreasing rate of maternal deaths, now show an increase in maternal deaths. So yes, there is an indication for vaccination. And in fact, all pregnant women should be prioritized as compared to non-pregnant women of the same age, especially those with risk factors. Their risks are higher. Non-messenger RNA vaccines are in rare cases associated with thrombosis, thrombocytopenia. Pregnant women already have the same problem. And that's why, for that reason, that mRNA vaccines are preferred, although we do not yet know enough about safety. However, if these vaccines are not available, then other vaccines should be given, which seems better than no vaccination, especially in women over 35 years old or with obesity. And also this morning we learned the incidence of obesity among pregnant women in Egypt is rather high, up to 40%. What about safety? We don't know. There are no randomized trials. If you look at direct side effects, they're not different from non-pregnant women. These are data from the industry, from the United States, 90,000 vaccination, but there are no follow-up. We also don't know if you can give them in the first trimester. Nowadays, guidelines from the American, the British, the Italians say, yes, give these vaccinations, but we don't know if they're safe in the first trimester. But if you look at recent, and I found 6 observational studies published since June 2021, including more than 10,000 pregnant women, apologies, who had been vaccinated, there was no increase in direct side effects related to outcome of pregnancy nor on outcome of the mother. However, that does not preclude that on the long-term effect of the fetus might be present. Uptake on vaccination, at least in the UK, where it has been promoted, it's still very low, especially young women, lower social classes, non-Caucasian. Fortunately, in the UK, there is a high uptake in pre-gestational diabetes. So their counseling apparently is correct, knowing that these women are at increased risk. These women also have a higher uptake rate. The uncertainty for pregnant women, of course, whether or not it's safe, is in a way logic. Fears for the baby, but also if you look at national regimens according to COVID and vaccination, etc., these guidelines have been changed so many times over the last year that has resulted in quite some confusion. Inclusion. Pregnant women are at increased risk of COVID infection. Despite the lack of ultimate proof of safety, nowadays vaccination is recommended, at least in most countries, but especially in women with risk factors. Women should be counseled properly. Messenger RNA vaccines are preferred. However, more basic studies and follow-up studies are necessary. Finally, if you look here at this meta-analysis, you'll find worldwide data that preterm births in an area of COVID is not increased. However, there is a decrease in most high-income countries, especially in spontaneous preterm births. We don't know why, but the same holds also for my country in the Netherlands, less spontaneous preterm births. Is that because women are at home, are not at work anymore? Are they stress related to other factors? But there are also other data. Data in Australia, where there is a dramatic decrease in the incidence of induced preterm births. 50% lower before 28 weeks and 20 to 30% thereafter. Less induction of labor with no difference in perinatal outcome in the overall population. For Australia and also in other countries with a high intervention rate, that might be a lesson that maybe before COVID, they were over-intervening far too much. So there are also these lessons that we may learn that for the future may be beneficial for pregnant women. Thank you very much for your attention.